So it's 3 minutes past 7:30. So with your permission, I'll get started.
Sure enough. Let's get started.
Okay. So good evening to all to this weekly huddle. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital, Banjara Hills. Joining me today is my colleague and co-host for the session, Dr. Praneeth Palamuri. In this huddle, we typically discuss clinical scenarios and patient case in an interactive, not rehearsed kind of way, where we pretty much narrate our thought process, what we think we should do for a particular patient, where we do talk about science and guidelines, but we also talk about the practical aspects of how to implement those, taking the local factors into consideration. The basic premise is to bring our casual discussion into a more organized platform. While doing so, once a while we pick up topics which are not directly patient care related, but they indirectly affect us in one way or another, be it news, be it research, or be it sometimes legalities, law, healthcare systems, what do you call, investments, recent news, whatnot, lifestyle. So a lot of these things at times we discuss. Of course, we mostly discuss about clinical scenarios, but sometimes we do pick up these relevant topics. And this time I did pick up a relevant topic, although it's a little bit sensitive topic for us to talk about. Having said that, it's an important topic for us to talk about, particularly given how much the medical fraternity currently in India is putting emphasis onto this. And I'm talking about the recent CCIM document, which kind of authorized few streams of postgraduate students in Ayurveda to perform few general surgery procedures. And if I have to recollect, I think there are about 57 or 59 of those which were listed, that these graduates, they should be able to get a short training. And after that, they should be qualified to perform these surgeries. Now, this whole scenario, which has been dubbed online and in the social media as so-called mixopathy, where you kind of mixing the allopathy field, which is what we practice, into an alternative medicine field like Ayurveda or whatnot, while giving equal importance and respect to alternative fields of medicine, namely Ayurveda and whatnot, the most point of contention was trying to mix the two different modalities of care provide together, which is Ayurveda and allopathy. So most of the rebuttal that happened online and in the social media was mostly related to mixing the two pathies together, dubbed as mixopathy. And Indian Medical Association, or the IMA, had been very vocally against this move. They announced a relay hunger strike from February 1st to February 14th, and it was concluded in Andhra Pradesh. If I remember correctly, that was in Vijayawada, where the last relay strike occurred on February 14th. And following that, they announced a mass petition movement from February 15th to go all the way to March 31st, where they had few things to discuss amongst their members, namely to be vocal against this so-called mixopathy. There was a call for non-cooperation in the training in terms of calling on the surgeon to say that when these alternative medicine graduates, particularly what has been mentioned in the CCIM document, that if these graduates, they do come for training, then we should have a so-called non-cooperation movement where we shouldn't train them as to speak, and various other things which were mentioned in those mass petition, which IMA intends, if I read it correctly, intends to bring it to their members and call for action. So this is something which is directly related to us, and a lot of our cardiologists or internal medicine physician are not directly involved in this, because most of the surgeries which are listed there are not directly affecting us, but they do affect medical care. They do affect how patients perceive the care providing that we give them. So I thought maybe I will discuss this with my Huddle audience, what their thought process is and how they look at it. What is the plan of action that IMA has reached out to you, or if you have to reach out to IMA, and what locally you are doing to support or not to support or to do whatever, or share the thought process regarding this particular aspect. And whenever we have got two parties involved in this kind of discussion, in this case, the party being the Ayurveda healthcare provider or the alternative medicine healthcare provider, and the second party being the allopathy. And in this audience where I don't have the second party participation, I will kind of act as the devil's advocate, where I will take the side of the alternative medicine practitioner just to get the discussion going, not necessarily telling you what I believe, but to share my thoughts as I am a person representing the Ayurveda or the alternative medicine. So I will be nudging you with some of the questions or some of the debates which has been happening online, just so that I get your thought process into it. So with this background, I'm going to get started with it, and I'm a bit hesitant in choosing my words because, as I understand, this is a little bit sensitive topic, and I don't want to step on my foot and speak out something outside of my league. So having said that, I always start my discussion with asking my co-host Praneeth to give his first input, and then I open it for discussion. So Praneeth, you heard the monologue that I gave for the last 6-7 minutes about the choice of this topic and what I want to bring this out. My questions to you are, what is your thought about this CCIM announcement that the PG students of Ayurveda should be able to perform few basic surgeries of various specialties? What is your stand on it? Is it something that you think is absolutely uncalled for, or it is something which is thought out idea, maybe work it out in the future, what not? How IMA has been taking a stand, what you have done in your capacity to show your support or lack of support. And I do want to highlight few things which also you can point out. The main rationale of why this discussion, why this suggestion or this order was passed was because there was this thought process that Ayurveda PG graduates, they do these surgeries anyway. It is not that these surgeries are new for them. They have been doing this surgery. It is just that they have not been part of a legal document before. So this announcement literally just puts it into a legal document. It does not change what they are doing. And secondly, when we talk about India, where the doctor-patient ratio is anyway less, and there is a huge discrepancy of doctor services, particularly surgical services in rural areas, these doctors, they can get trained and they can do basic services in the rural area. So what is the problem with that? So the idea was to facilitate this doctor-patient ratio by training them in a little bit better form so that they're able to perform this basic surgery. So these are some of the background thought process. Praneeth, tell us your thought about this and we'll open it for discussion.
Yeah. So good evening, everyone. So, firstly, I didn't know that Ayurvedic doctors they do surgery or not. Pardon my ignorance, but let me read out or tell me what about here are my thoughts on the current issue. So, firstly, as I said, pardon my ignorance. So, what I believe is there are basically 3 or 4 fields of the so-called practices of medicine: allopathy, homeopathy, the Unani and Ayurveda. So what I believe is the Ministry of Ayush gave permission, so-called, for the Ayurvedic PG students to perform surgeries. So first thing, I don't know that they do perform surgeries. Then if they were performing surgeries, the first question which I would be asking is about the new amendments kind of. I believe that surgery, whatever few surgeries which were are important thing. There is no surgery which is small, minor, or major, because ultimately patient can die because of any problem, even with a minor. So this requires a critical training, and those persons who are only critically trained and who know how to perform these surgeries should be allowed to operate. Be it in the terms of even those practicing allopathy also, if they are not properly qualified, then equally trained in their skill. So in that regard, the patient comes first. So even if it is allopathy or Ayurveda, the quality of the patient care should never be compromised. Then having said that, if they are allowed to practice in an attempt to reduce the patient doctor demand, then I would say there are other ways to look at it, and we are trying to solve a bigger problem with a quick fix thing, where earlier the with the same reason, without increasing the number of teaching institutes, the number of postgraduate seats by themselves were increased in the last couple of years, where the quality of education itself is getting diluted, and we can see the result where a lot of postgraduate seats and in fact super specialty seats are left empty. So just by mere increasing the number of seats, or just by allowing the available persons, be it allopathic doctors or Ayurvedic doctors, we are just trying to find a quick fix solution. So if we are looking at a long-term gain of giving a better quality or care in India, then the steps also should probably be in that regard. This for me looks like a quick fix. There are health issues very much at a basic level, and there's a lot of to improvement. And this I believe is a attempt to try to do a quick fix, which I don't think is going to solve the problem, and probably it is equally demanding. It's too much to ask from the Ayurvedic people also to do justice to this demanding job. I don't know how much they will be ready to accept this challenge. So I would say no. This is trying to fix things. So I would definitely not encourage this thing to happen. I, with due respect to each and every specialty, I have personally, I have no thing respect everything. Whichever works good for the patient, please take it. But surgery, I believe, is a technical thing which should be done by skilled hands, and given knowledge of what we are doing and all. And if uh, proper training is given, then in Ayurvedic itself, then there is no need to mix these things, and we should not definitely mix these things and against this thing. Regarding your follow-up question of what action did you take, or whether you did anything to these things right now, other than a mere spectator right now, I did not take any other active actions. So I would be, so far I did nothing to this issue. The only forum where I am sharing my thoughts. You know.
Thank you very much, Praneeth. I will invite thoughts from our other attendees. And let me see, Dr. Venkateshwarlu, are you able to hear me? If you are, could you please unmute yourself? Dr. Venkateshwarlu, can you share your thoughts about what we are discussing in terms of whether this is something which is which we should be taking it personally? It is something where what we can do at the ground, and do you fundamentally disagree with this decision of CCIM, or you think it's a relatively well thought out plan? Dr. Venkateshwarlu, are you able to hear me? If you are, you have to unmute yourself before you speak. Okay, some technical issue. Let me call upon somebody else from our audience. Dr. Srinivas Raju, you joined a little bit late. I hope you got the premise of today's discussion. We are talking about the CCIM's decision of allowing few Ayurveda doctors to practice selective surgeries. What is your thought on it? Do you think it is something which is the need of the hour? It is something which can be worked around? What is your overall impression onto this? Dr. Srinivas, if you could unmute yourself and share your thoughts, please.
Right. If I read the recent one, I believe our NCI, they're identifying a few doctors who can go and give services even in the tertiary care centers. So I don't think there's a hurry to encourage other specialties to go and do surgeries with a limited expertise. And if at all there is a shortage of doctors, then probably if they are trained for a number of years under a qualified person, they can do it along with that person in case of excess of workload, but not independently. That's my take on it.
I hear you. Yeah, I hear you, sir. One of the discussion that happens is, and we have to look in a more pragmatic way. And again, reiterate myself. I said it again, that because we don't have the other party representation in this group, I am just trying to be the devil's advocate where I support the decision for the sake of today's discussion, so that we have a little bit of balance here. So one of the discussion is more pragmatic than more theoretical. If you look at the rural and maybe tier 3 cities right now, there most of the, it's not that surgeries are not happening there. Surgeries are happening there by people who are, I wouldn't say less qualified, but I would say that they certainly wouldn't meet the qualification criteria of what Dr. Praneeth mentioned right now in terms of, there should be a certain level of training and whatnot, and what Dr. Srinivas Raju said that where you have a senior mentoring a junior and all those kind of things. Those things currently don't happen if you go to rural areas or if you go to tier 3 cities and whatnot. Yes, in an ideal world, there should be a trained MCH or an MS doctor going there and doing surgeries, but that doesn't happen right now. And in the current scheme of thought, it is very difficult to get a well-trained person to go and practice over there for whatever practical reasons that we have, and those are not easy fixes. So I agree this may be an easy fix, but if through an easy fix, if you can get even a mediocre performing person over there, which is better than the existing system, why not to take it? What is the problem in that? If you have a doctor who has done an Ayurveda training in his post-graduation, and now he has got a certain level of training in particular surgeries, and if he's able to practice those surgeries, which are not very high profile surgeries, yes, anything can go wrong in any procedure, but that they are doing in small towns anyway. And their RMPs may be doing surgeries. Their people who are not even MBBS pass out may be doing some minor procedures and whatnot. So these people will probably be better than the existing cohort. I'm sure none of them are going to sit in care hospital and perform surgery. I don't think that is going to happen. So what is the problem in there? And that is where I think some of the discussion comes, that why the current system of doctors who are not ready to go to a rural setup, and then when government is trying to do something to put these patients in a rural setup, they are stopping that as well. So what is the problem in that? So anyway, so that was my rebuttal to what Dr. Praneeth and Dr. Srinivas said. If you have anything to get back to me on that, please feel free to do. I'm going to invite other people for their discussion. Yes, Srinivas sir.
Yeah, probably see if they're working for a number of years under a qualified person, if they're certified, like they can do surgery independently, okay, allow only them to do it rather than giving a blanket decision wherein everyone can do it. Then it's going to lead to a lot of problems.
Okay, anyone else has got any other thoughts? Praneeth, you want to come back in what I said, or you want to hold your thoughts for later?
Let's listen to others as well, and I'll get back.
Okay. So let me call upon Dr. Santosh. Dr. Santosh is a cardiologist who recently joined Care Banjara. Dr. Santosh, I hope you heard the whole premise that I'm trying to put up, and believe me, I'm not blanket pro to this. I'm just doing this for the sake of discussion. So, Dr. Santosh, what is your take on whatever we are discussing so far? Dr. Santosh, we are not able to hear you. You may have to get close to the mic. Please unmute yourself and then speak. Dr. Santosh, we are not able to hear you. Do you mind logging out and then logging back in so that your audio is a bit better? We can't hear you at all. Let me move on. Dr. Anand. Dr. Anand is pass out from Care Hospital. Dr. Anand, I hope you heard everything that we are discussing about. I think a lot of these things are happening in Maharashtra, Tamil Nadu, Kerala, Andhra Pradesh, all these states which are very active. The IMA is very active over there. What is your thought on this?
Hello. Yeah.
Yes, Dr. Anand, please go ahead.
Yeah. So regarding this, one thing is, it is not like a previous issue where the students are less or doctors are less. Now doctors are willing to serve in the rural area uh, and come out from the cities, and they are staying in the rural area. I was visiting all rural places. Now young doctors are serving the rural people and giving a this type of what you call to the Ayurvedic surgeons to perform general surgeries is like just like a predatory poaching where they don't know any basics of modern medicine. Directly give the skill and asking them to perform the surgeries will definitely have a bad impact. They don't know what are the complications. They don't know what type of anesthesia you give, and if the surgery turns bad, what to do. They don't know. Just doing a surgery is not a matter, and this is only a temporary solution for the government to divert the attention of the people. So definitely we are protesting from IMA, and every doctor is against this, and this type of allowing the Ayurvedic surgeons will definitely bounce back on the government. Thank you. Yeah.
Thank you, Dr. Anand. And I misidentified you. I'm sorry for that. You work in Medicover Nizamabad, correct? I thought you were one of the care graduates. Right. Okay, perfect. Thank you, Dr. Anand, for those thoughts. Santosh, are you back? Can you test your mic to see if we can hear you? Okay, Santosh, we can't hear you still. There is some problem with your mic or whatnot. We are not able to hear you. Praneeth, are you able to hear Dr. Santosh?
No.
Okay, all right. So, Santosh, if you don't mind, I don't know what else you can do from your end to get things better. Dr. Venkateshwarlu, if you are able to hear me, you can unmute yourself at any given time to share your thoughts. We have Dr. Zakaria here. Dr. Zakaria is our DNB student at Care Hospital. Dr. Zakaria, please share your thoughts. What do you think about this? You guys are very upbeat with the current system, and you probably are more knowledgeable about how the system is working right now than what we are. Dr. Zakaria, please share your thought.
Yes, sir. Good evening, all. Yes, I would like to disagree with the argument, sir, that the allopathic practitioners are not willing or not willing to serve in rural areas. I have been part of a rural healthcare system for almost 3 years, and the argument so this argument is totally baseless. Just I would like to give one example, sir. So last time there was in 2016 there was a recruitment drive for rural areas. So out of around 600 odd vacancies, so the total applications were received from allopathic practitioners were more than 7,000. So rather than giving alternative medicine graduates, rather than giving the option rather than training them in surgeries, government should focus on improving rural healthcare infrastructure, better connectivity.
Dr.
Hello?
Zakaria, your point is well taken. Yes, Dr. Zakaria, we can hear you. Your point is absolutely well taken. The question here is that when we go the right way, then the right way may take 5 years, 10 years, a decade too. The problem is it is the need of the hour right now. So what is the problem in doing a quick fix at this point of time while we still work on the right fixes? So maybe, you continue to work on getting the healthcare infrastructure better, getting the roads better, getting the connectivity better while you also do this. So maybe right now, there will be trained Ayurveda doctors performing surgery, and after 10 years, there will be trained allopathy doctors providing surgery. What is wrong with that? Just because we are not choosing point 2, that doesn't mean we cannot choose point 1. That is one of the discussion which happens across the board. One another argument that used to come before I get to Somaraju sir. One of the other arguments that came through was that once you have alternative medicine doctors prescribe allopathy, because what happens is whenever we talk about real world situation, in the real world situation, you have got a
Hello.
certain layout. Yes, Dr. Santosh, we can hear you now.
Yeah, sir. Recently in Maharashtra, the MUHS, Maharashtra University of Health Science, they have started 3-month course of preventive cardiology for BMS, BHMS people. So the one day will come that they will start training the BMS, BHMS people for angiogram as well. So it is not going to stop for the simple surgery, sir. If you don't protest now, this will start coming in other branches as well. So I am against this mixopathy, and I'm against the BMS people, BHMS people doing surgery, sir.
Dr. Santosh, highlight some more. This is Maharashtra University doing, or this is Maharashtra government suggesting?
This is Maharashtra University of Health Science is the university that governs all the medical colleges and medical education in Maharashtra. So that has come up with a 3 months course of preventive cardiology for BMS and BHMS people, sir. And this is pioneered by one of the senior most cardiologists from the Maharashtra, sir. So our own people are doing all these things. So one day will come, they may train the BMS person 1 year in angiogram. You will start performing angiogram. So I'll not be surprised with that.
So my question to you, Dr. Santosh, is you don't think that to a BMS graduate, you can train them to practice preventive cardiology in 3 months? You don't think that is possible?
I do agree, sir, absolutely. But it is not going to stop. The way they have come up now with the surgeries, they will come up with this idea, sir.
Okay, so one of the concern is not the current idea. The concern is using this idea as a leverage. Things are gonna just keep getting worse.
Yes, sir. Yes, sir.
So that is one of the reasons why we need to protect so-called our field as compared to let somebody else poach into our field.
Yes, yes, sir.
The another argument that used to come was that once an Ayurvedic doctor, they start practicing into allopathy, then typically in the real world, they don't stop at that particular point where they are supposed to stop. There is always spillover. So one of the thought process is that if you call for 58 surgeries in the real world, there will be 580 surgeries which are being performed. Who is going to check up on that? If I'm allowed to do 4 surgeries, I'm going to do 40. Who is going to stop me from that? And these spillover, they happen in clinical research as well. When the TAVR was originally approved for high-risk patient with a STS more than 8, in the TVT registry in the real world, the average STS that patient were enrolled were 7. If the TAVR is performed, if TAVR is approved for STS more than 8, how can your average STS be 7 in a TVT registry? So in the real world, there is always this spillover. In the real world, you don't get the same kind of regulation or the thought process that was there in the book. So one of the argument is that then the problem here is if you go to some of the tier 2, 3 cities and sometimes in tier 1 cities as well, if you look at it, lot of alternate practitioners, They are your frontline workforce in your allopathic cardiac ICUs, in your allopathic medicine ICUs, and some of the house officers. They are your BAMS, BHMS, and your Ayurveda graduates who essentially are employed by the hospitals to manage as the frontline healthcare staff for ICUs and floor. I'm guessing, this is my guess, this is primarily related to cheap labor force that they get, because to hire those graduates is a little bit cheaper as compared to hiring MBBS graduate or an MD graduate or those things. And then what you essentially do is you kind of pseudo train them in the first 2-3 months where they're able to manage some of the things about ICU. And then you kind of, so the idea here is that allopathy itself has mainstreamed incorporation of alternative medicine into their mainstream care providing. So what is problem if the same thing is getting systematized, be it for preventive cardiology, be it for surgery, or be it for whatnot? That has always been there. And we have, and I'm not saying we means me and the attendees here, allopathic healthcare system has welcomed these graduates into their ICUs in a non-official way. And now when it is getting official, then what is the problem with that? So these are the kind of thought process which are coming across. If anybody has got any thoughts about this, they can raise their hand or unmute themselves before I ask our senior most Dr. Somaraju sir to give his input. Yes, Anand, please go ahead. Dr. Anand, please go ahead.
Yeah, definitely. That is a mistake of allowing Ayurvedic doctors to work for less in ICUs. Because of MBBS doctors, they are preparing for post graduations. So definitely that is a risk. And the Ayurvedic doctors, there was existence and survival was little less because they were studying the Ayurvedic and they are not getting any jobs. They were allowed into corporate hospitals. So now government has actually saved by issuing this GO. Government is trying to save this Ayurvedic branch, which is almost in a down loop. So that is one thing. And second, our doctors also, there is a separate course for homeopathic doctors such as gynec and ops. They can take an online course for 6 months and they can do some surgeries and they can be awarded some gynecology degree for a homeopathic or Ayurvedic degree. So this type of training should not be given to anyone unless they come through this proper channel. So definitely you should not encourage, and it will be mistake will be repented because most of them are working in corporate hospitals. Thank you.
Thank you so much, Dr. Anand. Santosh, you have something to add? Please unmute yourself.
Audible?
Yes, please. Yes, please go ahead.
Sir, regarding this posting of Ayush doctor in ICU, sir. So all the standard ICU has got a NABH accreditation. So this article has come up in Times of India in December 2020, where they highlighted this about the Ayush doctor manning the ICU and doing night duties and doing RMO instead of MBBS doctors. This has been highlighted, sir. So still, if you allow Ayush doctors into the ICU, in spite of this warning, now they are going to lose the license of their ICU and NABH accreditation. So in spite of all these set guidelines, still we are allowing this Ayush to enter into ICU and making that mixopathy. So this has to be stopped just because for the cheap labor. So we are downgrading ourselves, sir.
Thank you, Santosh. So what you are saying right now is almost like damage control of what we have done to our medical system. And of course, when we created a loophole, then somebody else is using that loophole. I think that is typically what happens. Having said that, let us hear what Dr. Somaraju has to suggest. And sir, if I could request you to take few extra minutes and share your thoughts, because I think these are the topics where your thoughts matter the most. If you could just share what you think and take a few minutes.
Anup, thanks for asking me. And though I'm not a specialist in this area, but I'm aware of the problem. And I just need one clarification from you. You used an abbreviation as to who made this decision to go ahead with all this. What was that organization? You said something. Who made this?
Sir, the body is so the body is Central Council of Indian Medicine. This
Who was
is
the members of this?
abbreviated as- Sir, this is what they say. Sir, this is a government assigned body which oversees all the Ayush
Yeah,
related.
that's enough. That's enough. Thank you. That's enough. I don't need more. I just want to tell
Yes.
you, while agreeing with many things that many of you said, first let us accept that the healthcare medicine has done, say allopathic medicine we are talking about, has done wonderfully well in the way it advanced in research, technology, and it made a difference in the way a lot of people are surviving now who are not surviving earlier, and some of the prolongation of life across the world may be attributed to medical advances. While I say this, the problem with medicine is not lack of technology, lack of development, but the problem with medicine we face today in this country and across the world is healthcare delivery systems. They miserably failed across the world with a few exceptions. That is everybody's knowledge. All of us know it. And then, having said that, what is the solution to help improve the healthcare delivery system? There is a famous saying long time ago. Somebody said, it is easier to send a person to the moon than make social changes. And healthcare delivery, the problems the society faces, which is healthcare delivery, if you look at it, can be classified as a simple, compound, complex, and wicked. Healthcare delivery comes under wicked problem. It is not easier. The care we deliver, however much we talk about it, is only tip of an iceberg of people who already fall ill. They already are made a diagnosis of something, acute problem or a chronic disease they have. They come to us, and some of them come to us, some of them don't come to us. But we only take care of the tip of an iceberg across the system. There is a concept called health systems delivery, health systems sciences today. We are all trained, all of us talking about today, and probably the present batches of medical education as they go through what is called biological science and clinical science. Today's healthcare delivery system requires that clinical sciences and biological sciences are not enough. We need more knowledge of chemistry, more knowledge of physics, more knowledge of mathematics, more knowledge of other technologies, say information technology, social sciences, economics, and information technology, molecular biology, and genetics. Our healthcare education miserably failed to deliver many of these things. We failed to change the education system as we have today. So before we go to others who are joining, you are talking about other systems of medicine joining us, we are ourselves inadequate. We have to do something about this. When you say health university, it is an oxymoron. That concept of health university is oxymoron. Health university don't take care of all those things I talked about. The American Medical Association came out with a document of these inadequacies of the present day education and came out with the concept of health system sciences. which includes the symphony of all this knowledge. And then, if medicine has to be delivered adequately, it has to be move beyond doctors and nurses, and it has to move to other categories of people who can come into the system, and they don't have to have formal medical degrees. And to be able to deliver all this, it has to be revoked. The health system sciences, the delivery systems has to, it's no longer possible. I remind ourselves of the Harrison's Principles of Internal Medicine 1950 edition as to physician-centeredness. That part was acceptable in 1950. It is no longer physician-centered. It has to move beyond physicians and beyond nurses, and say areas of medicine which can be delivered and repeatedly applied, and which are easier done by anyone who has some adequate training, has to move out of tertiary health system, doctors, nurses, and everybody, and including say village healthcare worker. And but the quality flows from the top, namely tertiary care health system, the specialists, the generalists, the generalizing specialists, and many of us. So in other words, we need a change. But at the same, while we say that we need a change, it cannot be done overnight, suddenly, like a few weeks of training for somebody. Somebody has done this just for votes. And that is the problem of democracy. And I'll say, whatever we do, it has to be done carefully in a pilot project method. In some areas, apply this and study this, how it succeeds, how it fails, and it has to be done gradually. And then I won't mention a particular profession. People at the top who run the countries, they want votes. And that's the reason why they do it fast and quick, without thinking about all this carefully. And if anyone has any more questions, I will be willing to answer. We need a change, but it has to be done differently. Thank you.
Thank you so much, sir. Certainly, sir, we certainly will get back to you. I'm going to ask if anybody has got any other comments or thoughts to share. And then I have few things to get back to you, sir, on this. Anybody has got anything to share? Dr. Zakaria, I have been reading your comments in the chat box.
Anup, just somebody talked about Times of India's comment. Stop quoting newspapers. They have no knowledge, and the people who write all this have no idea of anything they write. It is political. To remind you about Times of India's background, at the time when Gandhi was fighting for independence, Times of India was against getting India independence. Be aware of it.
Thank you, sir. Dr. Zakaria, I'm just reading some of your comments about this whole idea that since Ayush doctors have been working in the ICU, so what's wrong in training them? It's like legalizing daylight robberies because we miserably fail to control it. I completely agree with you. I absolutely agree that just because something is wrong, now you cannot legalize it. Well, the problem is that both the ends, we are the same person. We, the same person, did things wrong. And now we, the same person, are trying to block something else which is happening. It's not, the parties are not different. It is not that somebody is doing a robbery and you are trying to fix it. Here you yourself, if you consider this a robbery, which I don't have a good term for it, but since you mentioned, if you consider this as a robbery, then you are the one doing it and now you are the one trying to block something else. If two different parties are involved, then what you are saying makes a lot of sense. But here, the same hospitals, the same healthcare systems, which have been allowing this to happen so far, and when somebody wanted to legalize it, now that is when you are getting in trouble. which is not necessarily an which is not necessarily a contradiction. It's literally just telling that, okay, this is what you are doing, let's make it legal. And that legal you don't want. The reason why the legal you don't want is probably then they will have a right, they will have a say into that. And then the so-called cheap workforce that you are getting may not be a cheap workforce anymore, because now they know it is their right to get that job. Just like how a proper medical graduate knows it is their right to get the job. So anyway, that is just my thought on it. Santosh, your hand is up. Is there something you want to add to the discussion? Santosh, you have to unmute yourself. Yeah.
Yeah, no, sir. Nothing to add.
Okay. All right. Anybody else has got any other comments? Somaraju sir, I have got, yes, Srinivas sir, please go ahead.
Dr. Anup, like probably.
Oh, sorry, sir, I by mistake muted you. Can you please unmute yourself again? Srinivas sir, sorry, I by mistake muted you.
Yeah. No,
Yeah, please go ahead. Yeah.
treatment of heart failure, you can say is the same as doing an appendix surgery. So giving a license to do surgery is different from allowing them to give treatment for heart failure in an ICU. Surgery is a little bit more complex issue. So I don't think we can compare both.
Just on a lighter vein, Anup, once you train these people to do surgery, that committee would make a decision. All of them should go to these people for surgery first.
Sir, I can answer that question. See, this is a very common rebuttal that most of us, they talk about that, you know, if you are talking this, then why don't you go and get surgery? Because they themselves are saying that we are not.
Just said it in a lighter vein. I stick to my point of view. There is a need for change, but it has to be done carefully and differently.
Sir, talking about that change, I want to ask you this question. And you talked about health system services, which I think is a very crucial thing, which unfortunately in India we don't talk about when we talk about our general training. Here's my question to you. And this is something which US did very well with nurse practitioners. And not to say that it's an ideal system, but what US did with nurse practitioner in primary healthcare setup is certainly something to take home a point. So what my question to you is, if we take Ayush practitioners and if we teach them to become a healthcare provider with some basic training for surgeries and whatnot, put them in a good system, do you think incorporating them has a potential to create a better health system services, or you think that is just a disaster? I'm not talking about the skill set. I'm talking about a health delivery machine using a trained Ayush practitioner. What is your thought on that?
Absolutely. I'll tell you what, most of us who are participating here, we didn't become what we became by our DNA. We were trained and struggled to become what we are today. And then there are certain things that are repeatedly done and easily done in medicine today. And it doesn't require enormous say, knowledge and skills, and it requires training them in their skills. Anyone can do, whether it is a nurse or a technician or a nutritionist or anyone. You name anyone, they can do it. But it has to be done under the supervision of somebody who is a physician or whatever you may call it, or a surgeon or whatever it is. But the need for change is urgent. But how it has to be done, how carefully it has to be done, so that we don't harm people, we don't say destroy what is already existing. It has to be done. And American Medical Association actually fully agreeing that the present system of healthcare delivery, education, both are not adequate today. And original Flexner report, they found that the Flexner method worked for 100 years, but no longer anymore. It has to be redone today. They selected 13 medical colleges and ask them to adopt the systems we are talking about. The medical education they wanted to change, healthcare delivery they wanted to change. And so, in other words, a patient, when you see them as an outpatient or inpatient in emergency, at one point we see them. When they come for follow-up, we see, but they don't come follow-up, we don't see. And then, so the idea is the health of the people or person's health is not at one point, it is not cross-sectional, it is longitudinal, lifelong. For that to be done, doctors alone are not enough, nurses alone are not enough. You have to involve the whole community, right from tertiary care to primary care and village level care. That requires a change. You may call them by any name today, but we significantly failed to deliver this. And to say that doctors are willing to go, it need not. Doctor may be willing to go, but they don't have to be present. Train somebody else to do the same thing you are doing. And they are doable. And that's what American Medical Association came out with a document called Health System Sciences. And the whole system of delivery has to be redesigned. And that's what any one of you who is interested in want to access to this publication, let us know. We'll make it happen to you. Thank you.
Thank you so much, sir. Just to get the context right to our audience, because what Dr. Somaraju spoke was so much related to United States. I'll just get the context right. So about 120-25 years ago, the residency system in United States was very, very bad. It was very haphazard. There was no system as to in place. At that time, there were more than 100 medical colleges, so-called giving degrees at that time to the medical graduates without any, without any structure, without anything. You can think of that scenario as to what we are trying to do with Ayush practitioners, trying to train them to do surgery, something like that. It probably wasn't the same, but something of that sort. So at that time, Dr. William Osler, who is considered the father of this residency, he essentially got this whole structure during his time in Johns Hopkins. So in a way, the entire residency system in the United States can be credited to Dr. William Osler at that time. Flexner report came, if I remember correctly, in 1910 or so. And what Flexner was asked to do by US government was to look at the structure of what the medical training in US is. And believe me or not, with the Flexner report, 90% or so of the medical
Anup, one correction. Sorry
yes,
for
sir.
saying this.
Yes, sir.
Flexner report was not, Flexner was not asked by government at that time. It was asked, it is done by Carnegie Foundation in Rockwell.
Okay.
And
Okay.
it's not government. Later government adopted.
Okay. 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 So I'm just trying to recollect my memories over there. So essentially, with the Flexner report, more than 90% of the existing medical colleges who were giving so-called degrees and certificates, they were shut down because those structures were not in place. And what Dr. Somaraju sir is also saying is, at that time, Flexner report was considered groundbreaking. But it's been 100+ years now. And what what Flexner report kind of described how medical training and how medical graduate need to be may not be applicable currently. So there are at times when in discussion we go back to Flexner report saying that see how good of a idea it was. Well, it was a good idea at that time, but it probably may not be, it is not applicable in the current context. And in the current context, we have to think beyond. And what nurse practitioners in US have achieved is very similar to that. And we will be surprised to know that still a good portion of normal deliveries in US, even in cities, even in major cities, they happen by midwives. They're taken care of by midwives in the hospital, but they're taken care of by midwives just because patients are able to connect so well with them as compared to with a typical obstetrics and gynecologist who are more talk about more medical jargon and who always come up as a more intimidating personality as compared to a midwife who looks like
sorry to interrupt you.
Yes,
Adding to what you said, they tried a method of what you did in a pilot project in one of the countries in Africa, and they trained the nurses, and they were allowed to do deliveries, cesarean section, hysterectomies, and they did, and they compared, and they did a study, and they found the results of what they did were better than what doctors were doing earlier.
thank you, sir. So yeah, lot such examples. I'll cut short my US example. Lot such actual examples are there. And again, I can reiterate myself. I'm not saying this in support of what is going on right now. I'm just saying this to get the balance right because we need somebody to represent. I did not bring somebody to represent because I did not want this to turn into a baseless debate. But I'm trying to defend why I chose this topic to even be discussed. At the face of it, it looks like what IMA stand that it's taking, it is absolutely valid. We should not allow this to happen and we should hold our ground. It's a no-brainer and everybody should support that. I agree with that. People should support it. But at the same time, we do need to put our thought process into it, why this is happening, why in India also and in other countries as well, why the self-healers, as to speak, or the magic healers, they connect to people far better than a typical doctor is. And the rationale is again the same, that their system to deliver what they want to deliver, either in the form of a prasad or in the form of whatnot, they have figured it out way to connect much better than what some of the doctors have. And that is why these things are in place. So if we can train people and try and make them do a little bit of what we can with our limitations, what is wrong with that? The only thing which I find wrong with that is you literally let a can of worms loose. There is not going to be any regulation. That is what worries me the most. That when you let them open to, let's say, 4 options, that 4 will very soon turn into 40 without any regulatory environment. And that is where I think systems which work in US and other countries may not necessarily work at the face of it in India, because our regulatory mechanisms are not very well. Our self-policing literally does not exist, barring very few centers and very few doctors, and I'm using very few because I think they are less than 1% in India. The self-policing system does not work as a general. Regulatory system is almost non-existent. So when you create one such path, then it really opens up to a big nightmare, and that will create problem. Like what modern medicine did by allowing Ayush practitioners to enter into that hospital, and that led to another big thing that we're talking about. So that was my rationale of why I thought this topic deserves a discussion. Even if we support the stand that IMA is taking, even then it gives us an opportunity to retrospect, to think what we are doing and how we can make our system better by delivering something, or by what you call getting rid of that void that a healthcare system has created right now. So that is my thought on it. Anybody else has got any other thoughts? Please feel free to share. If not, then I'll ask Praneeth to give a closing remark on this unusual session that we are having this week. Anybody else has got any other thoughts? Okay, if not, then Praneeth, can you just add on your closing comments in those, and if you have also something to share after this 40 minutes of discussion, and then we'll close the session after that.
Yeah, no. So, relevant points being made by Dr. Somraju as the need of change of the healthcare system or the healthcare delivery is absolutely relevant. And as you said, it's a long-term process where we have to think broad and think for future, and the steps accordingly need to be taken. And the current step seems to be a shortcut fix, which we do oppose. As said, no disrespect to any of the specialty, but if properly trained and properly given the responsibility and accountability, then why limit to only one specialty? And ultimately, we want the patient to get better. Who delivers the care? Who cares? But I think that today's discussion was very appropriate. At least it, as you said, it gave us an opportunity to introspect of what is going on, and where do we stand, or what actions do we need to take, and at least a thought process that is in there. So I should say it was a good topic to discuss, and all the comments which were made by all the speakers were absolutely relevant and thought provoking. Thank you.
Thank you, Praneeth. Hopefully, we are able to incorporate this kind of discussions in the future as well. I thank all of you for joining and participating in today's discussion. And we'll see you again next week with another topic. If you do have any topic that you think I should incorporate, either clinical or non-clinical, please write to me or message me or call me or whatnot. My information is there on the invite that you get. And I'll be very happy to consider and put it up in an appropriate way. Thank you all for joining again. Good night. I'll see you next week. Thank you.